Erin, shall we? Leave me to open.
Okay, if everyone is here, we can go ahead and get started, I think. For those of you just joining, you'll see on your screen some information on how to join the simultaneous interpretation using the Zoom platform. If you have difficulties, please message in the chat if you're having difficulties with the simultaneous translation. Please let us know. And shortly we will get the presentation up on the screen. So that we can start. Go ahead and welcome everyone to this presentation, this webinar chaired by the SMC Alliance, focused on monitoring and evaluation for SMC. We are very excited to present this webinar today. We have 4 excellent speakers who will be talking about different aspects of M&E for SMC, coming from different country contexts. So we're very excited to present this morning. A quick housekeeping note, what we plan to do is have each presenter do their presentation, and they have roughly 15 minutes for their presentation, followed by a short question and answer just for points of clarification about the presentation itself. Then once all 4 presenters have had the opportunity to present their work, we will open the floor for a broader discussion about M&E for SMC. So if we are we ready to go with the first presentation? I'm not sure who is putting the slides on the screen.
Yep, I can start.
Okay, then as you're doing that, I will just mention that our first presenter is Monica Anna DeCola from the Malaria Consortium, and her presentation focuses on monitoring SMC programs from inputs to impact, results from implementing a comprehensive M&E indicator framework.
Okay, just want to confirm that everyone's able to see the presentation.
Yes.
Okay. So hello, everyone. Like I was introduced by Erin, my name is Monica DeCola. I'm the results measurement analyst at Malaria Consortium, and I'm presenting on the implementing the SMC Alliance performance framework. I'm going to start off today with a brief background of the performance framework and how it was developed, and discuss some implications of effective program delivery. And then I'll provide you with how that all led to the final framework and an overview of the framework itself. I'm going to discuss a bit more about how we operationalized the framework, and then show some results and discuss challenges and next steps. So the background of the framework focused on impact of seasonal malaria chemoprevention. When assessing efficacy of SMC in controlled settings, evidence shows that up to 75% of uncomplicated and severe cases of malaria can be prevented. This estimate would be affected by the timing of administration in relation to the transmission season, resistance levels in the area, and coverage or adherence to the drug regimen. And if we're looking at the number of cases of malaria in these eligible areas, we would see a dampening of that seasonal peak. So if you look at the right-hand side of my slide here, there is an illustration by Diawara et al., and it shows a range of model simulations for transmission in Kitamali, just as an example, prior to SMC and then during SMC implementation. And you see that that dampening that you would expect from implementation of SMC. So previously, when we were looking at monitoring and evaluation of SMC, we focused mostly on tracking indicators of coverage through end-of-round coverage surveys and impact through analysis of HMIS data, or doing intermittent studies of efficacy through case control or resistance studies. However, outside of controlled settings, the impact of the program when delivered to scale is dependent on many different factors. And so we wanted to answer the question of what happens when we don't reach that expected impact in an area based on those studies. So like I had mentioned, outside of coverage and efficacy, there are many other factors that go into impact, including the transmission dynamics, changes to access in healthcare, seasonality, but also quality of program delivery and methods of measurement. So we wanted to build a rigorous monitoring and evaluation framework, which looks at the program as a whole to be able to validate whether the program is being delivered as intended, whether that delivery is effective, to identify any bottlenecks, and to determine if the target population is reached equitably, and then ultimately how that all leads to impact. So by drawing together data from across all the different elements of the SMC program, we can assess the relationship between the different aspects of implementation. So for example, the inputs and processes and outputs, and then the expected results, where that would be looking at coverage and impact. The framework also takes into account the different relevant external factors that could affect program implementation, results, and collection of data and interpretation of those data. So here I'm showing the main components and factors within the components that all come together to form the framework. The framework has an overarching aim, and it was designed to be reflective of the SMC program's intended purpose. So that was defined as to safely prevent malaria cases in eligible children living in areas targeted by SMC campaigns within the intended period of protection. And then we identified different program objectives that would encompass the different elements of the program, and that all came together to help achieve that overall goal. So those were supply and demand, readiness, timeliness, acceptability, and safety. And each of those objective areas are mapped across the different process, outcome, and impact components of M&E by defining key indicators. So with each of those indicators, we included definitions, the aggregation level, reporting frequency, the data source, and any challenges and considerations. So how do we link inputs to impact and why? Here I'm showing an example of how we can link implementation to the results. So we may want to look at the number of field supervisors per community distributor to assess if that affects the proportion of CDDs who have received a supervised visit. And then we notice less supervised visits among areas with supervisors with more CDDs assigned, for example. Then we can link that to supervisors ensuring proper support to CDDs to maintain the protocol, engage with the caregivers and child properly, to explain the program correctly for to each of the caregivers, and that would lead to higher caregiver acceptance, for example, with the caregiver belief in SMC efficacy. And then ultimately to high coverage, so day 2, 3 coverage, and then a reduction in cases. So that's a very simplified example. And then why do we link inputs to impact? So first we want to answer the question of, are we reaching our target coverage levels? Why or why not? We could triangulate coverage estimates with program performance. So do we see high coverage in areas where we also see evidence of high quality implementation? In some cases, we can include indicators for looking at factors affecting impact, such as other programs being implemented in the same area. Also, having the data in one consolidated system allows for timely analysis and fast response if needed. So for example, with Malaria Consortium, we have our in-process monitoring with our LQAS surveys. So having all of that data in one place, you can quickly see where we are or are not reaching our target, and then respond faster. And then tracking inputs and performance over time helps keep track as we scale up to new geographies. And it gives us an idea or understanding of implementation over time to make sure that we are implementing to the same standards. So to operationalize our framework, we had 3 main steps. The first 2 were defining the framework and indicators and reviewing the data sources. And then the third and final step we're looking at right now, which is presenting the results. And the working group piloted different methods of data collation and came to a consensus of the best method. We created different forms and templates for upload into a centralized database and dashboards for live updates of those key indicators. So to operationalize the framework, we first reviewed the current data sources and tools, the flow of data, those who are responsible for each of the data sources, and their timelines to ensure ease of data entry and possibility of integrating any new indicators into the current tools if required. So for example, if there was a different indicator that we wanted to add to the LQAS, we had consultation for that. And then we collated, we needed to collate the data into one centralized database. So at Malaria Consortium, we have a software from Logalto, and we refer to that as the Project Results System, or PRES. And we have 4 main routine data collection tools that contain all of the variables needed to calculate the indicators in our log frame. So those are the microplan, the end of cycle reports, the end of cycle surveys, and then the end of round surveys. And all of those data tools are entered into these custom forms that sit within the project results system. And that data is entered at the lowest administrative level, so the LGA or the district. And those forms are then linked to a Power BI file, which contain linking forms that have all of the information on location and time. And in Power BI, we've coded all of the indicators using the variables from PRES. So they're all calculated within the Power BI logic. And then we develop data visualizations and dashboards within PRES that can be automatically uploaded just as we upload more data. And then those indicators are then used to create the log frame, which are grouped by those objectives. And the log frame is then connected back to PRES by entering the data. Back to the PRES, which is where we display all of our data. So by entering the data at the lowest administrative level, it can be used and displayed at various different stratifications. So you can show country level visualizations, or district level visualizations, or global level visualizations. So each of the country has the ability to use and manipulate their data as they like. So I'm going to show you some results. Here I'm showing an example of a dashboard that we put together that monitors supply and demand objective indicators. So this dashboard mainly shows input indicators, and it will provide us with a general idea of the scale of the program across the different countries. So at the moment, it's showing 2021 data, and here are some specific examples of supply and demand indicators. The number of doses procured, we have displayed there. The number of blisters of SPAQ distributed for each cycle for each country, and the number of courses administered per distributor team per day. And then we also have some readiness indicators in there. They are community distributors per field supervisor team, and then number of field supervisors recruited active during the whole SMC campaign, and then community distributors enrolled for the SMC campaign. We can also track to see if we're providing sufficient levels of input. So for example, looking at the number of CDDs per field supervisor team and the number of distributors per capita of target population, and triangulating that with the number of courses administered per CD per cycle. Here is a dashboard where we're showing a few of our acceptability indicators. And so some examples of acceptability indicators are proportion of caregivers who remember key SBC message about SMC. Proportion of caregivers' knowledge of AQ importance, and proportion of caregiver knowledge of age of protection. And then on the bottom right-hand corner, you can see that we can make these very easy data visualizations to show any relationships between the indicators. So herd of SMC and knowledge of age of protection. And we can see if that data is correlating well. And then we can also categorize that data by country to see those trends. By collating our data into one centralized database, it also allows us to utilize the framework for different additional analyses. So for example, this dashboard we created to monitor our plan versus our actuals. And it also makes it easier to do analyses comparing data across different data sources and different M&E components. So if we want to look at, our microplan data, our input indicators, and compare it to our end of round coverage surveys. So looking at, for example, our implementation and then our results. And then that also makes it easier for us to do this is that same data, but in different data visualizations. So here we're looking at two outcome indicators. On the left is coverage of day one SPAQ administered with CDDs observing DOT. And then the graph on the right is the coverage of compounds visited by a CD. And we're comparing these indicators to the number of courses administered per CD per day to assess if the quality of the implementation affects the outcomes. And this data is aggregated by LGA in Niger or district and color coded by country. I wanted to also mention some challenges in operationalizing the framework. So it's still pretty difficult to obtain the data in a timely manner, especially some of the data that needs to be validated with the Ministry of Health before we can use it. Also, although we designed the data collation process to be as easy as possible, we've noticed that there still needs to be data cleaning and manipulation in order to upload the data. One problem that we're having is that the name of the LGAs and districts have various spellings across the different forms, which makes it difficult for linking and different cycles. Also, I still think that there's quite a few indicators at the moment, so we're thinking about distilling down into some priority indicators for these dashboards. Our next steps are, like I had mentioned, was to sort of focus on some priority indicators and then feed those back to the program staff through maybe like mobile dashboards or bulletins or something like that. We're still entering data from the 2022 survey. So once that's finalized, we can start comparing across the different years, and then we can also link that to the impact analysis. So answering questions on what different factors or different confounders need to be taken into consideration when we're doing our impact analyses. That's the end.
Thank you so much. And you are right on time. Very much appreciate it, and a very excellent presentation. I really appreciated the clear format as you walked through the different steps. I'd like to open the floor now for a few quick questions. Any questions of clarification or that type of thing before we launch into the next presentation. But remember, we will be holding some time at the end of all 4 presentations for a larger discussion around M&E. If you have a question, please go ahead and either raise your hand or put the question in the chat and I can read it out. I'll give you a minute or 2. And I can't see all the participants. So if anyone sees someone raising their hand, please let me know, but I don't see anything. I think your presentation, Monaco, is so clear that nobody has questions of clarification. So if that is the case, I will pass on.
Hi, Sex. I was trying to raise. Sorry, I was trying to raise my hand, but I can't see where.
Oh, okay. Please go ahead. I can hear you. Yes.
Okay, Erin. Sorry. Yeah, thank you very much for the wonderful presentation. My name is Orezi Adekoyibo from Catholic Relief Services, Nigeria. So, wonderful presentation, but I was looking at one of the challenges to implementing this framework, and I can see that one major challenge is the number of indicators that are being tracked for SMC. So I was just wondering, looking at all the countries that are implementing SMC, and is there a way that we can have like standard key indicators that want to track for SMC, so that across all implementing partners, across all countries, the focus will be on certain indicators. It would be good to have indicators that nice to have, the ones that are really important, the ones that really affect our program implementation, rather than just having a very long list of indicators and make the work kind of tedious. So is there a way that we can harmonize and just have a streamlined indicators for SMC?
Yeah, that's a very good question. So the performance framework is posted on the SMC Alliance website, and they have an extensive list of indicators. And then within there, they have marked which ones are like the priority list that you should be monitoring and evaluating for each of the programs. I think personally, what we've done is we have we have a lot of those indicators from the performance framework, but then within our own organization, we had a lot of consultation across the different aspects of the program. So the operational team, the research team, the M&E teams, and they have also provided input onto what kind of indicators that they would like to have recorded. And I think from there, what personally our organization needs to do is distill down into what is the most important. But within the performance framework itself, there is indications on which ones are the priority and which ones are nice to have. Sorry, it sounds like someone's mic is glitching. I don't know if you guys were able to hear my response.
Yes, we were.
Yes, I could hear it just fine. Let me see. Oh yeah, Charlotte put a link to the toolkit in the chat if folks would like to look up that reference on M&E. It's in the chat bar. So I think at this point we should probably move to our next presenter. So I'm going to toss over the microphone, so to speak, to Andre, who will present our next speaker. Thank you.
Oui, bonjour à tous. Notre prochaine présentation sera faite par le docteur Joël Ateba, qui est le secrétaire permanent du Programme national de lutte contre le paludisme du Cameroun et qui va donc nous parler, nous entretenir sur les méthodes d'enquête pour déterminer combien d'enfants ont été traités dans tous les cycles en mentionnant les résultats du LQAS au Cameroun. Docteur Ateba, merci de nous entretenir. Vous avez la parole.
Merci beaucoup à tous. J'espère que vous m'entendez. Il pleut des cordes à Yaoundé et donc les conditions ne sont pas optimales pour la communication. Vous devrez peut-être tendre l'oreille. Et on a des problèmes d'énergie qui partent et qui reviennent. Donc je remercie le fait que je sois le prochain à passer parce que d'ici là, je risque d'avoir des problèmes d'énergie également. Voilà, donc là, je vous présente la couverture de la CPS au Cameroun par le LQAS, évaluée lors du monitorage externe par le LQAS. Diapo, s'il vous plaît. Bien, peut-être juste revenir sur le contexte du monitorage. La CPS est mise en œuvre depuis 2016 et elle couvre 2 régions du pays, les régions septentrionales, le nord et l'extrême nord. Nous savions exactement combien d'enfants avaient pris des médicaments par passage à travers des fiches de pointage de nos agents sur le terrain, mais nous voulions savoir quel est le pourcentage qui avait pris des médicaments pendant tous les 4 cycles, la CPS, quel est le pourcentage qui avait pris la moudjakine au 2e ou 3e jour de chaque passage. Et c'est pour cette raison que nous avons initié en 2020 des enquêtes ménages et que nous poursuivons au fur et à mesure. Vous avez à votre droite les représentations de ces 2 régions dans la partie nord du pays. Alors, la méthodologie utilisée, c'est LQAS. Donc, nous avons choisi la méthode LQAS, échantillonnage aléatoire, et c'était 5 aires de santé par district sanitaire. Donc, dans chaque district, nous choisissions de manière aléatoire 5 aires de santé. Et dans ces aires-là, nous visitions 20 ménages dans chacune de ces aires. Un ménage est considéré comme cible lorsqu'il abrite un enfant cible de la CPS, à savoir un enfant qui a âgé entre 3 et 59 mois. Un ménage est classé comme traité si tous les enfants cibles du ménage sont effectivement traités. Autrement, le ménage est considéré comme non traité. Alors, cette méthode permet la classification des différents lots, mais aussi de savoir le nombre exact d'enfants dans le ménage cible. Cette méthode permet éventuellement de classer les aides de santé en termes de aires de santé qui aura été performante ou non performante. Le calcul de couverture administrative et thérapeutique par district et par région étaient également permis. Diapo, s'il vous plaît. Alors, sur ce diapo, on présente la couverture, la couverture administrative des enfants. On peut constater, selon les données DHIS2, qui est vraiment le canal par lequel les données sont collectées, classiquement dans notre pays, les données sanitaires, toutes les données sanitaires. Nous avons eu un module DHIS qui a été ouvert, et en exploitant ces données, on peut voir que la couverture administrative des enfants traités par la SPAC varie d'un cycle à l'autre, mais quel que soit le cycle, elle est au-delà de 90%, et parfois dépasse 100% pour la cycle. Diapo, s'il vous plaît. Alors, ici, c'est la couverture des enfants traités 4 fois. On peut voir que presque 100% des enfants au 4e passage avaient reçu le traitement au cycle précédent. On peut le voir dans la région du Nord et de l'extrême Nord, dans chacune des régions, c'est vraiment ces pourcentages-là qu'on a. Diapo, s'il vous plaît. Alors, maintenant, pour ce qui est de l'adhésion au traitement, on peut voir sur ce diapo que quasiment 100% des enfants avaient pris la modiakine à J3 du 4e cycle en 2020 notamment. Diapo, s'il vous plaît. Alors, sur ce diapo, nous présentons les raisons de la non-prise des médicaments retrouvés. Alors, on peut voir vraiment ces raisons, elles sont, on en a les principales, il y en avait 5. Vous avez les enfants qui sont absents pendant le passage des distributeurs, le refus des parents ou des gardiens d'enfants, des ménages qui n'ont pas été visités par les distributeurs, des enfants qui viennent des zones qui ne sont pas couvertes par la CPS, mais qui arrivent après la visite de nos agents sur le terrain, et puis les enfants qui ont été oubliés. On les a pour l'année 2020, pour l'année 2021 et pour l'année 2022. Diapo, s'il vous plaît. Alors ici, c'était les raisons de la non-prise de la modakine à J2 et à J3. Ici, nous prenons le résultat de la CPS 2020. On peut voir que ces raisons sont entre autres les vomissements, le rejet par l'enfant en bleu, les enfants malades, les parents qui avaient oublié de donner la dose de J2 et de J3, la perte des médicaments ou le refus des parents ou des gardiens d'enfants. On peut le voir pour chaque cycle, le cycle 1, le cycle 2, le cycle 3 et le cycle 4. Diapo, s'il vous plaît. Ici, c'est en 2021, les mêmes éléments, c'est-à-dire les raisons de la non-prise des doses des J2 et des J3, la modakine. On peut le voir à chaque des cycles. Diapo, s'il vous plaît. Et ensuite, en 2022, les mêmes raisons réapparaissent. Diapo, s'il vous plaît. Donc, ici, on a voulu voir si, en fonction de la tranche d'âge, il y avait une différence significative pour la non-prise des médicaments de J2 et J3. Et cette différence n'est justement pas significative. Donc, on n'a pas, quelle que soit la tranche à laquelle l'enfant appartient, la non-prise de la dose de J2 et J3 est vraiment dans les mêmes proportions. Et cette méthodologie, le LQAS, nous permet justement de mener ce genre d'analyse. Diapo, s'il vous plaît. Alors ici, nous voulons présenter les défis que nous avons rencontrés et puis les actions qui avaient été prises. Vous avez comme premier défi le ménage non visité par les agents distributeurs. Et là, ce qui a été fait, c'est que nous avons augmenté la supervision de proximité, avec plus d'agents de proximité, pour couvrir plus de distributeurs, pour s'assurer que, effectivement, ces ménages étaient visités. Et il y a eu de l'administration de la SPAC, telle que prescrite par les directives. Cette administration est suivie dans le cadre des supervisions. La non-administration de la dose de J2 et J3 de la modakine par les parents ou gardiens d'enfants comme autre défi. L'action plus c'était l'augmentation de la sensibilisation des ménages pendant le deuxième et le troisième jour à travers les membres des réseaux d'associations féminines. C'est un autre canal qu'on a utilisé pour rappeler la prise de ces doses à J2 et J3. Et puis, il y a la mise en place de la stratégie leader ménage pour rappeler aux parents de donner les médicaments à J2 et à J3. J'appuie, s'il vous plaît. Voilà, je vous remercie.
Merci beaucoup, docteur Ateba. Je pense que je vais laisser peut-être la place à s'il y a des questions qui viennent des participants avant éventuellement de poser la mienne. Juste une, deux questions avant de passer à la présentation qui suit. Non, il n'y en a pas. Je voudrais juste poser juste une question de commentaire. L'administration, dans les mesures prises sur l'avant-dernière slide,
Docteur André, la Guinée est là, hein? La Guinée veut poser des questions.
faut lever la main. D'accord, allez-y.
Les mains sont levées.
Et merci beaucoup, merci à notre collègue du Cameroun. Et nous, c'est par rapport à l'identification des enfants ayant bénéficié les 3 passages. Est-ce qu'au cours de leur étude, ils ont tenu compte des paramètres liés au marquage des ménages et pour mieux faciliter l'identification des ménages? Est-ce qu'il y a un enfant, comme il a si bien dit, un enfant éligible dans ces ménages? Est-ce qu'il est effectivement conforme au marquage? Est-ce que l'enfant bénéficie d'un traitement? Je vous remercie.
Docteur Ateba?
Allô?
Oui.
Allô? La communication n'est pas bonne. Je ne vous suis pas bien.
Vous pouvez reprendre la question, s'il vous plaît?
OK. Merci au Cameroun, merci pour cette étude. Je disais que la première condition sine qua non pour l'échantillonnage, il faut qu'il y ait dans un ménage qui ait un enfant éligible et qui a réussi le traitement. Est-ce que maintenant, au cours de votre étude de l'évaluation pour se rassurer si les enfants ont bénéficié du traitement, est-ce que vous avez tenu compte des marquages? Tel que sinon en Guinée, dès qu'un ménage, un enfant est traité dans un ménage, nous faisons les marquages pour faire l'identification. Ou bien s'il y a un enfant éligible, malade encore, nous tenons compte aussi dans notre système de marquage. Est-ce que tel a été le cas au cours de votre étude? Voilà ma question.
OK, là j'ai bien entendu la question. Oui, effectivement, le marquage était fait et c'était la première indication que le ménage avait été visité. Après, il y avait des astuces pour savoir que l'enfant avait effectivement pris les médicaments. C'était notamment la plaquette qui était couplée, ainsi de suite. Donc, le marquage, effectivement, était un des premiers éléments qui nous permettait de savoir que le ménage avait effectivement été visité. Merci.
Merci beaucoup. Il y a des questions dans le chat. Je crois qu'on va essayer de les prendre à la fin dans la discussion générale et peut-être passer à la présentation suivante avec le docteur Daniel Coco du projet Impact Malaria au Niger, qui va nous entretenir sur les méthodes d'enquête pour déterminer combien d'enfants étaient traités dans tous les cycles et présenter les résultats de l'échantillonnage en grappes aléatoires au Niger. Docteur Coco, vous avez la parole.
OK, merci André. Je tiens à remercier les organisateurs du webinaire que vous offrez à projet PMA Impact Malaria de présenter ces réflexions sur les 2 méthodologies qui ont été utilisées pour l'enquête des ménages au Niger. Et avant tout, je tenais à remercier aussi le PNLP Niger pour son implication, le ministère de la Santé dans son ensemble, qui sont en réalité les maîtres d'ouvrage de l'enquête qui a été réalisée. Charlotte?
Vous voulez que je partage, pardon. Donnez-moi une seconde.
Oui.
Pardon. Attendez, pardon.
Désolé hein, pour... OK, so next slide, prochaine slide. Donc, comme contexte, il faut noter que le Niger a démarré la CPS depuis 2013 avec un district pilote. Et puis, la couverture n'a cessé d'augmenter progressivement au fil des années. Le projet Impact Malaria fournit une assistance technique et opérationnelle au Niger depuis 2018 jusqu'à ce jour. Et l'extension est allée progressivement. Nous sommes passés de 6 districts en 2018, aujourd'hui à 21 districts qui sont couverts en 2022 dans les 2 régions cibles qui sont Dosso et Tawa. Prochaine slide, Charlotte. Il faut noter que chaque année, ce sont environ 1,4 million d'enfants qui sont ciblés. La distribution des médicaments se fait en porte-à-porte et en site fixe. Et cette distribution se fait, on va dire, en parallèle de cette distribution, il y a des enquêtes de ménage qui sont menées par des, on va dire, des acteurs indépendants qui viennent des secteurs tels que l'éducation nationale, l'agriculture, les ONG locales, qui conduisent les enquêtes de ménage pour pouvoir monitorer la campagne. Alors, dans le cas du Niger, à quoi sert, on va dire, le monitoring de la campagne? Je me réfère un peu à la boîte à outils du SMC Alliance qui nous dit que le monitoring sert à contrôler et évaluer la qualité de la mise en œuvre, la couverture, l'efficacité, et surtout aider les programmes nationaux et les partenaires à prendre des décisions et à définir les priorités. Donc, c'est ce qui nous a guidés depuis 2019 jusqu'à 2022. Next slide, Charles. Donc, Impact Malaria au Niger, depuis 2019, conduit des enquêtes de ménage. De 2019 à 2021, les enquêtes de ménage ont été conduites selon l'échantillonnage en grappe. Et puis, suite à la publication de la boîte à outils de la CPS et aussi à l'expérience du Cameroun par rapport au LQAS, nous avons changé de méthodologie en démarrant le LQAS, la méthode de sondage par contrôle de la qualité de l'eau, depuis 2022. Donc, cette expérience nous permet de pouvoir avoir un recul en termes de réflexion sur les 2 méthodes, en termes de résultats et en termes de considération opérationnelle et en termes de considération statistique. Next slide. Nous sommes donc permis de faire une comparaison entre les 2 méthodes, entre la méthode en grappe et la méthode LQAS. Dans le cas de la méthode en grappe 2019, 2020, 2021, il s'agissait de faire des choix raisonnés et sanitaires basés sur la performance. Donc, dans chaque région, 2 sites étaient choisis sur la base des performances. Et à partir de ces sites choisis, il y avait un tirage aléatoire des aides de santé. Et à partir de ces aides de santé sélectionnées, il y avait des ménages qui étaient visités. En général, c'était un grand nombre de ménages, pour environ 270 ménages par district qui étaient visités au cours de chaque cycle. Dans le cas de LQAS, tous les districts sont inclus schématiquement. Et puis, à partir des aides de santé, il y a un tirage aléatoire avec des choix de villages. Et dans chaque lot, qu'on appelle district, 50 ménages sont choisis, donc environ 10 ménages par village, donc 50 ménages. Avec le LQS, nous avons aussi l'opportunité de comparer l'intervalle de confiance. On a une bonne intervalle de confiance entre 90% et 95%. Donc, voilà un peu les considérations statistiques par rapport à ces 2 méthodes. En termes de considération opérationnelle, next slide. Il faut noter que pour pouvoir mettre en œuvre l'échantillonnage en grappe, il nous a fallu 32 personnes par cycle pour pouvoir visiter les ménages. La durée de la formation, la méthode en grappe, c'est de 1 jour avant le démarrage du premier cycle, mais une demi-journée avant chaque cycle, les autres cycles qui suivent. La durée du monitorage, c'est environ 3 jours. Cependant, la charge de travail est très énorme, puisqu'on visite pas 270 ménages par district. Et il a un coût d'environ $10 par enfant. Pour ce qui concerne le LQAS, il fallait mobiliser près de 46 personnes par cycle. 3 jours de formation avant le premier, on va dire, le premier passage, et ensuite 1 jour avant chaque passage pour le LQS. Donc, environ, on va dire, 3 jours de formation préliminaire, donc un peu plus important par rapport au 1 jour pour la méthode en grappe. Le monitorage dure 5 jours, surtout à les villages, et puis le temps de travail est réduit par
Docteur Awuku, on ne vous entend plus. Allô?
le résultat. Charlotte, next slide. Quand on regarde le taux de couverture de la première dose, c'est-à-dire la dose qui est administrée sous observation directe des distributeurs et les taux d'administration de la deuxième dose et la troisième dose, on a, quelle que soit la méthode utilisée, les résultats sont quasi similaires, identiques. Que l'on utilise la méthode en grappe ou la méthode LQAS, on constate que nous avons les mêmes tendances en termes de couverture, première dose et deuxième et troisième dose. Next slide. Pour ce qui concerne, lorsqu'on s'appuie sur la recherche de preuves dans les ménages et qu'on évalue par l'une des méthodes, on constate effectivement que pour la première dose, les tendances sont pratiquement identiques. Même pour la deuxième et troisième dose, on constate que dans la méthode LQAS, la couverture est un peu plus basse, le taux d'administration est un peu plus bas. Cela se justifie essentiellement par le fait que la méthode LQS a été conduite 7 jours après la campagne. Donc, du coup, les mamans n'ont pas eu l'opportunité de pouvoir cocher soit les 4 CPS ou soit n'ont pas gardé les blisters pour que les moniteurs puissent les observer. Par contre, dans le cas de l'enquête en grappe, ça se déroule en process. Les blisters sont encore disponibles à domicile et les distributeurs, les moniteurs peuvent les observer au moment des visites de ménage. Next slide. Ce qui concerne le niveau de satisfaction, on a le même niveau de satisfaction, en même tendance. Près de 100% des ménages sont satisfaits, quelle que soit la méthode utilisée. Ils nous répondent, on a les mêmes tendances en termes de messages. Okay. Next. En termes de recommandations, à l'issue de la mise en œuvre des 2 méthodes d'enquête de ménage, GRAP et puis l'enquête LQAS, nous pensons que les 2 méthodes sont toutes 2 valides pour évaluer la qualité de la campagne. Et donc, finalement, le choix de l'une ou des méthodes va dépendre de la disponibilité des ressources financières et aussi des priorités des PNLP. S'il y a plus de ressources, on peut se lancer dans le LQAS. Si on en a un peu moins, on peut aussi faire la méthode en GRAP. À la fin de la journée, on a le même résultat. Ça dépend des ressources et des relatifs des PNLP. Il faut aussi noter qu'il serait intéressant pour les programmes nationaux, lorsqu'on planifie de mettre en œuvre des enquêtes de ménage, il faut aussi planifier de mettre à disposition ou un budget pour pouvoir intervenir, pour pouvoir mettre en œuvre des mesures correctives lorsqu'on observe des gaps, on va dire, assez importants. Donc, on fait l'enquête, mais c'est pour aussi prendre des actions spécifiques. Alors, il faut me sécuriser un budget qui permettra de pouvoir prendre des actions spécifiques. Je pense que je suis à la fin de ma présentation. Je dis merci pour ta attention. Et s'il y a des questions, je suis disponible. Merci à tous.
Merci beaucoup, Daniel. Merci pour cette présentation claire. Je ne sais pas s'il y a des questions, 1 ou 2 questions avant de laisser Erin introduire la 4e et dernière présentation de ce webinaire.
Il y a une main levée, André.
Je ne vois pas la main d'ici, mais Ange.
Bonjour à tous et merci beaucoup, Dr. Poku. Je suis Ange Landela du projet PMA Impact Malaria. Je suis basée à Kinshasa, RDC. Ma question est la suivante. Quels sont les défis rencontrés durant les 2 enquêtes, si vous voulez comparer les 2 enquêtes, c'est-à-dire les enquêtes en GRAP ou bien LQAS, pour évaluer la qualité de la campagne? Merci.
OK, peut-être on va prendre la deuxième question également de Fatoumata. Comme ça, Daniel peut répondre aux deux.
Ok, bonjour tout le monde, docteur Sidibé du Mali. Et vraiment, je remercie le présentateur pour la qualité de sa présentation. C'était assez fourni. Maintenant, ma question, c'est par rapport au coût qu'il a parlé. On a vu le coût d'un enfant quand il s'agit de la méthode de Grave et aussi le coût d'un enfant quand il s'agit de LQAS. Moi, je veux un peu comprendre parce qu'il s'agit là du monitorage ici. Est-ce que c'est en fonction, ils ont réparti ça entre les enfants qu'ils ont pris? Ça, c'est ma première question. Maintenant, il a aussi dit que la méthode de LKAS a été faite 7 jours après la campagne. Et la méthode de GRAP, est-ce en même temps que la campagne ou bien dès les premiers jours après la campagne? Maintenant, pour les défis, ma question a été prise en compte. Je vous remercie.
Merci, merci. Daniel?
OK, merci André, et puis merci aux personnes qui ont posé les questions. Je vais commencer avec la première question de Ange concernant les défis. Je pense les avoir présentés dans la partie, on va dire, contraintes opérationnelles ou considérations opérationnelles. Donc, le premier défi, c'est la taille de l'échantillon on va dire, à visiter, de ménages à visiter. Dans le cas du LQS, on voit que c'est un petit nombre de ménages à visiter. Et donc, du coup, on peut aller vite, on peut être efficace en termes on va dire, les moniteurs ont plus de temps pour poser les questions au moment, donc on a une meilleure qualité. On constate aussi qu'on a, dans le cas du LQS, l'intervalle de confiance qui est assez intéressant, 90-95%. Cependant, le défi pour le LQS, on le voit clairement, c'est la question du coût. Il faut pratiquement $36 pour chaque enfant. Là où pour la méthode en grappe, on part pour environ $10 par enfant, pratiquement. Voilà, donc c'est ce que je peux noter comme on va dire, défi opérationnel à prendre en compte au moment des choix. C'est pour ça qu'on a fait comme recommandation finalement. Les deux méthodes ont pratiquement, quand on regarde les tendances entre les résultats, on a pratiquement les mêmes tendances. Le choix devra se faire sûrement si les fonds sont disponibles au niveau des PNLP et on va dire, si c'est une priorité du programme, il peut poursuivre l'enquête LQAS. Sinon, s'il n'y a pas suffisamment de fonds, on peut aussi faire l'enquête en grappe, qui est assez intéressante en termes de résultats. En termes de méthodologie de grappe, quand LQAS, effectivement, on a voulu le faire en end process. On l'a mené 7 jours après, avec l'idée, effectivement, de s'assurer que les enfants ont pris toutes leurs doses au moment où on fait l'enquête. En ce moment-là, on peut poser toutes les questions sur la première, la deuxième, la troisième dose. Alors que dans le cas de la méthode en grappe, anciennement utilisée, on le faisait pendant la distribution. Et donc, du coup, quand on passait dans un ménage, on va dire le deuxième jour, le troisième jour, il y avait la possibilité que l'enfant n'ait pas fini son traitement. Donc, ça créait une confusion dans l'analyse des résultats en termes statistiques. Donc, voilà un peu pour répondre à la question de Fatoumata Sidibé du Mali. En termes de coût, oui, on a réparti le coût en termes d'enfants touchés finalement. Quand vous regardez avec le LQS, c'est 270 ménages par district. Avec la méthode en grappe, c'est 270 ménages par district, alors que pour la méthode LQS, c'est 50 ménages par district. Quand on rapporte sur le nombre d'enfants touchés à la fin, on a un peu le coût qu'on a estimé. Voilà.
D'accord, je vous remercie.
D'accord, merci beaucoup Daniel. Je crois qu'on va se réserver un peu de temps à la fin pour avoir une autre discussion. Et donc, je vais laisser la place à Erin pour introduire la dernière présentatrice. Merci.
Merci, André. And thank you to our presenters. Both of those were fascinating presentations and really contribute to our understanding of different approaches to M&E for SMC. I'd now like to turn to our final presentation this morning or afternoon, and that is from Vivian Shigbo from CRS, and she will be speaking to us about key considerations for a successful digital SMC campaign, benefits to the M&E system and to SMC. And I'm not sure, Vivian, if you'll be showing your own slides. There we go. Okay.
Sorry, give me 1 second, please.
Sure, go ahead.
I'm sorry, Charlotte, please, could you help me share the presentation? I'm having a bit of a challenge.
Sure,
If
no
that's
problem.
okay. Thank you. Hey, thank you, Charlotte. Good morning, good afternoon, everyone. My name is Vivian Chigo. I work as an ICT4D advisor with Catholic Relief Services. I will be co-presenting with Ochai Ako, who works with the National Malaria Elimination Program in Nigeria as an ICT4D specialist. So in this presentation, we are going to talk about some key considerations when planning for a digital SMC campaign, and then we'll look at the benefits to the M&E system with experience from Nigeria. Next slide, please. Yeah, so first I'm going to discuss briefly on the reasons for digitalizing SMC campaigns. And here are just a few reasons. There are lots of reasons, but I'll just discuss briefly on these 3. So the first one is to improve transparency and accountability. Technology can help you gain insights into the work activities of field staff and also help you identify anomalous events in the field. For example, you can track real-time data on how many children administer the SMC drug or SPAQ each day for each cycle. Then the second reason is to use data for decision making. So with data collected in real time, you can effectively make decisions, and this can help you to identify and correct gaps before the end of the campaign. You can also easily monitor children that effectively receive all 4 cycles of the SMC drug. So that's another important reason. And then the third reason is to leverage population data for national priorities. What I mean by this is that data collected during household enumeration, for example, can be used for other health campaigns, such as insecticide treatment campaigns or river blindness campaign. An example is what was done in Benin. The household data that was collected for SMC campaign was used in other health programs, so they didn't have to do enumeration again. So that also saved cost. Next slide, please. So for a successful digital SMC campaign, there are 3 key areas that should be considered. And that is the people, the process, and the technology. As we can see here, we have people at the top. And what this means is that without the right people resources, we cannot have a successful digital campaign. Next slide, please. So yeah, here are some key considerations under the people component. First, you want to prioritize personnel selection and recruitment. As always, this is a very, very important component for an SMC campaign. You want to ensure that you have the right personnel for the campaign. And apart from having the right personnel, you want to ensure that you train them on the digital components of the campaign. This is a very important component as well, as we know that there are different levels of training during SMC campaigns, from the national level training down to the sub-district or the community level training. Then you also want to ensure that you communicate early and often. Communication is key. If there are issues in the field, there should be a mechanism in place to resolve those issues. It could be through WhatsApp or by call. Then consider building the capacity of government partners so that they can utilize the digital features for campaign implementation. And this promotes ownership. Then leverage in-country capacity as much as possible so that, and then build a feedback loop where you can get feedback from enumerators to improve the usability of the software or application that is being used in the field. So it's always good to get feedback from the enumerators in the field so that the software, the application that is used can be improved upon. Next slide, please. So these are some of the processes involved in an SMC campaign, from micro-planning, training, supply chain, registration and drug administration, down to monitoring and evaluation. So for the micro-planning phase, you want to consider using geospatial maps or digital maps as against the use of manual maps. A lot of countries have started adopting the use of digital maps, and this will help to ensure that all the communities are covered during micro-planning, and we don't have the issues of missed population during the actual implementation. Then for training, consider leveraging digital solutions for training attendants. This can help to also fast track the payment process because you already have a digital attendance of participants who attended the training. For supply chain, digital tools can be used to carry out a warehouse assessment, for example, where the SMC drugs or the SPQ will be stored. You can also leverage digital tools for stock taking, inventory, amongst others. Then for registration and drug administration, you want to leverage use of mobile devices with an application for household enumeration or registration, as well as tracking the drugs given to children. For this particular campaign process, you want to consider the type of application you're going to use. Will it be a customized software, or will it be an open source? And also, because campaigns are usually very huge, you want to consider the mobile device management process. So if you're going to be procuring mobile devices for the campaign, you want to make sure that you have a process or a system in place from the beginning, or from charging the phones to setup of the mobile application to distribution to the healthcare workers. Then you also need to think about retrieval and then finally return back to the warehouse where they are stored. And then the last one is the monitoring and evaluation. Here you want to consider using digital supervision, monitoring and evaluation tools, which are aggregated in real time. And this will help in facilitating decision making. Next slide, please. So the last area of focus, this is the technology component where we have the software. I already mentioned you want to consider what type of software you're going to use. Will it be an open source or will it be a proprietary software? Then for hardware, I mentioned this as well. Are you going to procure mobile devices, or are you going to adopt the bring your own device approach? Ochai is going to speak more on that. Then for data storage, you need to think about how will the data collected be stored. Are you going to store it in the cloud or on a physical server? And how will you also manage data privacy, which is a very, very important thing to think about because you're collecting sensitive data. Then for dashboards, you want to consider having a dashboard where you can see at a glance what's happening in the field based on selected indicators. Then finally, consumables. For example, you need to think about SIM cards. If you're procuring devices and you're going to be collecting real-time data, you need to have SIM cards in the phones. Then you need to think about the mobile data plans for internet connectivity. Then another example is child cards, which are given after the child has been administered the SMC drug. Next slide, please. Okay, so for more information, please check out this handbook on digitalizing malaria campaigns. This handbook was developed by CRS and some of our partners, AMP, the Alliance for Malaria Prevention, and Opt SMC. So I'll hand over to Ochai for the second part of the presentation. Thank you.
I'm sorry, who is speaking next?
That's Ochai.
Okay. Thank you, Vivian. Thank you, everyone. My name is Ochai Ako. I work with the National Malaria Elimination Program, Nigeria. So I'll take us through some slides highlighting the achievements we've had from digitalizing SMC implementation in Nigeria. Next slide. So our background is just a simple one. We were tasked with a donor to digitalize SMC implementation in Nigeria, and that was in 2021. We did a pilot in a state called Gombe for the 2021 round of implementation, and we had lessons learned from the pilot implementation, and that was used to develop and deploy a scale-up plan, which we used to digitalize 3 additional states in 2022. And in 2022, we had further lessons learned meetings that has helped us to also come up with an updated scale-up plan to scale up into 10 states for 2023. Next slide. Okay, so we use an approach called the BYOD approach, and this leverages on the devices of the campaign personnel, the field staff who will be carrying out the work on the field. And this is expected that they bring a compatible phone, and we have the SMC application installed on their device, and this helps them capture the necessary data for the implementation. And we also leverage on the fact that they are all connected to the internet on one way or the other, and we're able to see real-time data from these devices that are connected to a central database. I'll highlight some of the benefits of the BYOD approach we use in Nigeria, and we have discovered our device provisioning and configuration process has been decentralized, and this means we send in the specialized field support staff who go to meet the cities where they are working, especially in the health facilities, and carry out the necessary provisioning for them to be ready for the activity, rather than bringing them all to a central point at the state level, which requires some additional logistics and operational arrangements to be made. And secondly, instead of buying devices as grant procured devices issued to the field staff, we instead of buying the entire device needs. So in Nigeria, we are currently in 10 states, we are currently using about 50,000 CDDs, community drug distributors, to carry out the activities in these states, the 10 states. And if we're going to have them, if we are going to issue them devices, meaning we're going to procure devices for them in the amount of about 50,000. And this, we all know how much it is. If you want to do the conversion, let's say we have $200 per device, and you have that $200 times the 50,000 device needs, you're going to procure for the activity for 10 states. You could imagine the cost of the procurement. And this, we already know that since we are not procuring the total device needs for the implementation, we are significantly reducing the cost of the implementation. Next slide, please. Next slide. So we'll just show you a brief highlights of what we have been able to achieve using technology. We have data-driven decision-making during the implementation. We are able to daily track our coverage, percentage coverage in terms of the children reached. We are able to strengthen the monitoring and supervision process, and also improve the commodity reconciliation process. So this is a picture of a Power BI dashboard we use to track the activities on the field. Next slide, please. With the real-time data reported, we are also able to do some simple analysis on the data. And on the graph on the left, sorry, we have the percentage of active teams from the first day of each cycle. And on the left, we are doing a correlation with the percentage of beneficiaries reached, especially on the first day of each cycle. And we have 2 states currently being analyzed in this picture. So on the one for each cycle, we see we have like between 20 to 80% of the teams ready for work. We noticed in 2 states where we did a comparison, we have the Kwara State and the Kano State. We saw the correlation between teams who were ready for work on the first day and the quantity of work they were able to do on that same day. And we also realized, due to the challenges with using technology, switching from paper to technology, they face so much, hitches trying to reach their target on the first day of each cycle. But when you go to cycle 2, cycle 3, and cycle 4, you will see an increase in the quantity of work they're able to do, meaning they were more comfortable using the technology to carry out the activities. And this, amongst other analysis, we're able to do using the real-time reported from the dashboard we use. Next slide, please. Also, we're able to achieve a realistic code tracking process using what we call the beneficiary ID. So this is a unique ID assigned to each child registered using the technology during the implementation. So we're able to track the spark given to the child from the first cycle up onto the 4th cycle, and we're able to know the number of children who received the 4 consecutive doses for each of the cycle. And for the states like Kano, because we're using technology, we're able to see a pattern or a trend in their data. And we realized from the first cycle up onto the 2nd cycle, there was a disconnect between how the work was carried out, especially in the 2nd cycle. We realized in the States, there was a heavy rainfall that affected work, especially for the first day, and flooding incidents that also made people leave their homes. So it was difficult to follow the children who were visited from cycle 1 up to cycle 2. So most of the children started their code tracking process from cycle 2 up to the cycle 3, and that is why you could see the state was or is colored in red in the graph on the screen. Next slide, please. We're also able to use the real-time data collected from the field to track the quantity and the quality of supervision done by the health facility supervisors. We, from the first cycle, we discovered most of the CDDs were not observing dots. They were always quick to finish their work. We start work, let's say 9 a.m. in the morning, and they finish their work at 11 a.m. And we're wondering what was happening, although they were reaching their targets for the day. But we wanted to know why that trend or that pattern existed. And we discovered the CDDs were not observing dots, especially in cycle 1. And the obvious reasons were because the supervisors who were supposed to monitor the activities were not actively doing that. We went the next step to use this data we collected from the field to understand why the CDDs were not observing dots. We discovered rather than the health facility supervisors going to the field, they were all seated in the health facilities during the activity, doing nothing. So we displayed this data to the state, and the state picked it up and had the punitive measures set in place, ensuring that any health facility supervisors who did not go to the field to work will not get paid. And that's boosted the quality of work, especially in cycle 2, 3, and 4. We noticed the decline in the in the rate of CDDs who were not observing adults. They were actually doing the work and observing adults and ensuring that these children were adequately visited and the rights pack administered to them. And next slide, please. Yeah, so other achievements we use, we got using technology. Yes, we're able to digitally track attendance during trainings, understand the number of hours that people sit for trainings and see the impact it has on the quality of work. We're able to also come up with digital activity timesheet for field staff who are in the field, and also have the bulk bank account verification for this person who also worked during the implementation. And this helped us improve the processing of their payments at the end of the activity. And also we noticed the state and partners were had their capacities built to use the technology for their own implementation, especially their own activities at their level. Next slide, please. This also highlights some of the challenges we faced during the use of the technology and some of the solutions that were applied, and this formed our lessons learned. And one very key challenge we witnessed was the limited mobile network coverage across the country. This really affected the rate of reporting of data in real time. And we have also learned that mixing several mobile network operators helps to minimize the impacts that have, especially when you discover a network works best in a particular location, but doesn't work best in another location. And in that case, we're able to ensure multiple mobile network operators networks are being used to ensure a seamless transmission of data for those places. And another key challenge we faced was the loss of data due to stolen or missing or damaged device, which we know when that happens, when the devices are not synchronized, that data cannot be recovered. And one way we are able to mitigate that was to encourage defense synchronization to ensure whenever the device, whatever happens to the device, will not have so much impact on the volume of data that will not be able to recover. And in that case, where we are unable to recover the lost data, then we have the field staff go back using their route maps and work plans to identify the affected beneficiaries and recollect the data in that situation. Next slide.
Please, oh, there we go. I was just going to ask to please wrap up soon. Thank you very much. Very interesting presentation. I think I'll start with seeing if anyone has any clarification questions for the last two presenters, and then we'll open the floor to a broader discussion. Any quick questions of clarification on the last presentation? I'm not seeing any hands raised. Okay, so maybe then we'll pivot and go launch into a broader discussion of the overall perspectives on M&E for SMC.
Excuse me, I've got a hand raised.
Sorry, I'm very sorry. I didn't see your hand. Please go ahead.
Okay, thank you very much. I'm Andrew Anguida from Malawi. Thank you for the presentation. And my question is to the second presenter. I just wanted to find out from him how they manage the use of personal devices in the wake of a project like this one. Bearing in mind that, for example, the data collectors will need to have credit in their phone so that they can do synchronization. How do you manage that into, as you also know that these are personal devices and they're using WhatsApp, they're using Facebook, they will be eating on the same data that you give them for the project. How do you manage that process, making sure that the credit that you give them for use should be used only for work and not for any other activities? Thank you very much.
If one of the two presenters would like to respond to that question.
Yeah.
Okay, should I proceed?
Yes, please, go ahead.
All right, thank you for that question. We leverage on the facilities the field staff use to provide internet for their personal devices and add the cost of that, let's say, synchronization they have done during the 4 days of activity for each of the cycle to their remuneration. So it's a form of token because the quantity of data being synchronized are in kilobytes. So we see that the moment they start working from the first day to the 4th day, they hardly use up to 500 megabytes or so. We did a rough estimate of how much it will cost for them to purchase that amount of data, and we add it to their remuneration for the end of the cycle. Over.
Thank you for that clarification. We have just a few minutes left in our time slot, but I wanted to see if there were some broader thoughts or ideas that came from these 4 very interesting presentations.
Hi, Erin. I also have my hands up.
Okay, thank you. I'm sorry, I can't see all the hands that are up, but please go ahead.
Okay. Apologies for joining late. May I know the software that is used for the application?
And your question is to the last presenter, correct?
Yes.
Okay.
Sorry, can you repeat the question? I didn't get it clearly.
May I know the software that is used for the application?
The software, the question.
Okay, thank you. We use the Red Rose solution, our SMC implementation in Nigeria.
Thank you.
Thank you.
Maybe, Erin, if I may, I've
Yes,
tried to take questions that are in the chat, and there is a question from Suleimanu, I think addressed to Cameroon, the presentation from Cameroon, saying that la comparaison des 2 méthodes s'est-elle faite sur la même année pour assurer la comparabilité des données. I don't know if Dr. Ateba is still online to take this one.
I think it was for the Niger presentation.
Yes, that was for the Niger,
Yes.
for Daniel, yes.
OK, merci beaucoup, André. La comparaison, c'est 2 années différentes, 2021 et 2022. Voilà, mais ceci n'empêche pas la comparabilité. Les années n'ont pas d'influence, parce que ce sont les méthodes qui vont influencer plutôt que l'année.
D'accord. En complément, moi, j'avais une autre question par rapport au coût. Étant donné que en LQAS, le coût est plus élevé par enfant, mais qu'on touche moins de ménages, et que on a l'inverse dans l'analyse en grappe, est-ce qu'au final, si on fait un coût, non pas par enfant, mais un coût global, on ne se retrouve pas au même niveau de coût finalement? Quelle est la différence sur un coût global? Juste comme ça pour analyse, hein. Peut-être que le chiffre, on ne l'a pas, mais peut-être qu'en termes d'analyse, ce serait intéressant de voir, compte tenu de la réduction du nombre de ménages, compte tenu de savoir quelle est l'ampleur sur le coût global.
Oui, c'est peut-être possible à analyser, mais il faut noter que dans le cas du LQAS, puisqu'on fait des tirages dans, on va dire, dans 5 villages différents,
oui.
Donc, la distance joue pour beaucoup. La distance entre les villages joue pour beaucoup.
D'accord, ok.
C'est vraiment la partie logistique qui va jouer beaucoup. Alors que dans le cas de l'emploi dans le grappe, dans le même village, on prend pratiquement tous les enfants, donc pratiquement près de 30 à 50 enfants par village. Donc, dans le même village, il y a une grosse partie d'échantillonnage.
D'accord.
Oui, on peut faire cette analyse, on peut regarder ça comme ça en détail.
OK. La question pour le Cameroun, can you speak more about the reasons for refusal, especially the major reason? Ça, c'était une question qui est venue de Orezi, qui était pour le Cameroun. Et je me suis trompé tout à l'heure. Je ne sais pas si Dr. Ateba est toujours en ligne. Non. Non, je ne pense pas.
Non, non.
Okay, and there was a last question from Sue asking, how do you manage data in the mobile phones of the staff? And this question was for the last presentation on digitization.
Hello?
Yes, please.
Can you repeat the question, please?
How do you manage data in the mobile phones from the staff, the data protection?
Okay. All right, thank you. So for data protection, the application being used comes with the 256-bit AES encryption. You currently use, I think that's one of the world standard now, meaning whatever data is being collected on the mobile device is not stored on the mobile device. Rather, it's in some encryption codes or hash keys, as they put them, and that only communicates with the server. And the moment the session is over for the activity, the data is destroyed. And we only have a copy of that data on the cloud server. So no unauthorized access to the data on the device, no matter what you do at any point. Over.
Thank you, Oko. There is a last hand we might take. We are almost over time, but a last hand, Landry.
Merci. Allô?
Oui.
Oui, merci André. Ma question c'était pour la dernière présentation sur du Niger, sur la digitalisation. J'aimerais savoir quels sont les défis liés à la qualité des données rentrées par les agents mobiles distributeurs. Sur le nombre de mobiles distributeurs, est-ce qu'il y a des difficultés? La qualité, les données sont de bonne qualité? Si oui, quels sont les défis? Et maintenant, quelles sont les solutions qui sont mises en place pour améliorer ces données? Ça, c'est ma première question par rapport à la dernière présentation. Et là, j'ai aussi une deuxième question, si je peux me permettre aussi, pour docteur Daniel Koto, par rapport au prix à l'évaluation des coûts. Parce que selon son évaluation, il ressort que la méthode en gramme est moins coûteuse. Maintenant, j'ai quand même cru entendre que la méthode en gramme ne couvre que quelques districts. Et la méthode LQAS couvre tous les autres districts. Peut-être comment s'est fait peut-être l'évaluation? Est-ce qu'on a pris une évaluation au niveau des districts ou on a pris de manière globale?
Okay. I don't know. The last presenter from Nigeria, have you got the question?
Yes, can you repeat the question again? Sorry.
Yes, the question was mainly about what are the challenges that you encountered in the data quality, when using the methodology you applied in Nigeria.
Okay, thank you so much. Like it comes with every digital data collection, there is a margin of error you will expect in the data collected. But we have a structure to ensure if that happens at any point, we're able to identify the teams that have erroneously entered the data, especially in the cases of widows we witnessed and referrals. We had erroneous data entered for some children that were false positive for widows and referrals. And for this, we're able to analyze the data every evening and identify those CDDs who are affected, and manually, or we confirm from their supervisors if that was done in error, and we have that corrected. So we don't wait till the end of the cycle. We do that at the close of work every day to ensure we are able to reconcile the data even before the end of the cycle. Over.
Thank you. Thank you, Ako. And the last question for David. Daniel.
Merci beaucoup, André. Merci beaucoup. C'est une très bonne question de la part de son nom, de mon ami du Cameroun, Landry du Cameroun. Très bonne question. Effectivement, on va continuer à travailler cette question de coût. Je pense qu'il y a eu une question de André, une question encore de Landry. Mais clairement, pour nous, on va dire que la méthode en grappe a couvert à la fin de la journée l'ensemble des districts qui devaient être, qui ont bénéficié de la CPS. Donc, comparativement au LQAS, où on a couvert 19 districts, dans le cas de la méthode en grappe, on a aussi couvert 17 districts sanitaires. Donc, les coûts sont pratiquement similaires pour l'ensemble. Alors, quand on rapporte au nombre d'enfants touchés, ça nous donne un peu le coût qu'on a présenté là. C'est sûr qu'il y a des éléments de coût à prendre en compte, notamment la charge de travail, les éléments supplémentaires, qu'on devra sûrement continuer à analyser de façon plus approfondie avec des spécialistes en économie de coût, j'imagine, en économie de la santé. Merci beaucoup.
Merci beaucoup. Je vais laisser Erin conclure. Merci à tous les présentateurs et je laisse la parole à Erin pour conclure.
Merci, André. I will just also give my thanks to all of our presenters who did an excellent job across the board with sharing their findings and results from their work in different countries. I think we've all learned a lot about different aspects of how M&E can be improved for our SMC programs. Super exciting to see the developments in this area. A number of people had asked in the chat whether the presentations would be available after this webinar, and I just want to let people know that they will be available on the SMC Alliance website afterwards, so you can find them there if you want to go look in more depth. And with that, we're just a tiny bit over time, so I will finish by saying thank you to our wonderful behind the scenes interpreters and organizers at MMV who helped pull this together. We really appreciate all the hard work that went into the behind the scenes so that we could all learn from this excellent webinar. So big thanks to everyone, and we look forward to seeing you at one of our next events. Thank you all.
Thank you. Bye-bye.
Bye.
Thank you, everyone. Bye.
Thank you. Bye-bye. Merci à tout le monde. Merci à Linda et merci à Dr. André.
Muito obrigado a todos.
Merci.